Good morning, everybody. I'd like to welcome everyone to our webinar series, Battling Emerging and Re-emerging Epidemics and Designing Mitigating Strategies, COVID-19. This is the second of the series of our webinars, and today's title is COVID-19 Linking Quantitative Models to Data. My name is Olcay Akman from Intercollegiate Biomathematics Alliance, and I'm faculty at Illinois State University. It's my pleasure to be the moderator of today's webinar session, as I mentioned, titled Linking Quantitative Models to Data. During these trying times of the COVID-19 outbreak, some of us from different institutions have quickly come together and adapted to deliver collaborative outcomes in the form of designing this novel webinar series, special journal issues, and various articles, commentary, and research articles. What we are seeing today is a joint initiative from the University of Wisconsin-Whitewater, the Intercollegiate Biomathematics Alliance, Illinois State University, Arizona State University, and George Mason University. We are going to discuss complex mathematical modeling challenges, theoretical and practical fundamental principles, and model-based prediction issues related to understanding of transmission dynamics of the current COVID-19 pandemic. As one of the organizers, I am delighted to be in the company of an amazing group of organizers that I had the pleasure of working with. I like to thank all of my co-organizers right now, and I will quickly introduce our organizers, my co-organizers. Dr. Aditi Ghosh is an assistant professor of mathematics at the University of Wisconsin-Whitewater. For the last several years, she has been serving as a mentor for the National Alliance for Doctoral Studies in Mathematical Sciences, and she is the Intercollegiate Biomathematics Alliance's Cross-Institutional Undergraduate Research Experience Program Advisor. Dr. Anuj Mubai is an associate director at Precision here of Precision Medicine Group, visiting scholar at Intercollegiate Biomathematics Alliance, and he is currently teaching at the Department of Mathematics at Illinois State University. He is also associate research scientist at Prevention Research Center in Berkeley, California, and adjunct faculty at College of Health Solutions of Arizona State University, as well as Biocomplexity Institute and Initiative of University of Virginia. He was formerly the director of MTBI, the famous MTBI, the Mathematical and Theoretical Biology Institute of Arizona State University. Dr. Padmanabhan Sheshayar is a professor of mathematical sciences at George Mason University and currently serves as the director of the STEM Accelerator program in the College of Science, as well as the director of COMPLETE, which is the Center to Outreach Mathematics and Professional Learning and Educational Technology at George Mason University in Fairfax, Virginia. Ms. Rebecca Perlin is a program coordinator for the presidential award-winning and nationally recognized NSF and NSA-supported MTBI research experience for undergraduate summer program. She has been working with multiple programs to improve students' diversity. And last but not least, Ms. Sarah Leisman is the Education and Outreach Coordinator for the Intercollegiate Biomathematics Alliance. She is involved with the organization of the symposium on Biomathematics, Ecology, Education and Research, or fondly known as Beer Symposium. And she is also involved with the cross-institutional undergraduate research experience career program as a mentor. Why are we organizing a series of panel discussions on COVID-19? Current burden is, as of yesterday, the United States is still struggling with over 4.5 million total cases, with over 150,000 deaths due to COVID-19. Still increasing at a rapid rate, and worldwide millions of total cases with hundreds of thousands of deaths being reported, while the disease has its damaging effect in at least 6 continents. So in spite of vast literature on mathematical modeling, the infectious diseases, the use of models in predicting COVID patterns so far have been limited. Existing models have been valuable in the literature for other infectious diseases, but they were not designed to support the types of critical decisions that are related to changing COVID information. For instance, the models from Imperial College and Institute of Health Metrics and Evaluations have been way off in predicting disease burden accurately, primarily because the data are highly underreported and contact patterns may be changed substantially. Unpreparedness and uncertainty. For instance, public health departments around the globe need to allocate COVID-19 tests amid limited supply, prioritize the deployment of healthcare staff, and direct health resources to those who need them the most. Although COVID has resulted in numerous problems to individuals and society as a whole, but one must say that because of COVID pandemic, mathematical modeling concepts and techniques are gaining popularity, with most mathematicians aiming to explain things for non-quantitative audience. But natural questions that come to our mind are, why have models failed earlier in predicting trends and patterns? Are there any scenarios where models are helping? How to prove the accuracy of the results? There are a vast number of modeling results. Which ones to consider? Are there any protocols in accepting those results? Are there any best practices in face of incomplete and changing empirical information? Can models be used to predict how long COVID-19 will be with us and when it will end? The focus of today's webinar series will be on discussion related to importance of data from the point of field collection and reporting to the point of interpretation for public consumption. The impact of data quality on the reliability of modeling and forecasts, linking quantitative models to data accurately and precisely, effective uses of various types of data for different aspects of COVID-19 related information. So to this end, let me introduce to you all our eminent panelists. Today's panelists include Professor Julian Arino. He is a professor in the Department of Mathematics and Statistics at York University, Canada. Professor Jane Heffernan. She is the professor in the Department of Mathematics and Statistics at York University. Professor Benjamin Reidenhauer in the Mathematics Department at the University of Idaho, and Professor Arne Srinivasa Rao. He is the professor in the Division of Health Economics, Medical College of Georgia and Georgia Augusta University. The rest of today's activities will include the following format. We'll start with a 5-minute presentation from each of our 4 eminent panelists. And if you can see me, as the time gets closer, I'll raise my hand on the camera, not on Zoom. So this 5-minute presentations from each of the panelists will followed by panel discussions around 30 to 40 minutes. We'll have 5 questions to ask to our panelists. And then we'll also request audience to provide their questions on the chat box of Zoom. And we'll collect these questions from this chat box and ask to panelists, and ending the panel discussions with closing remarks by each of the 4 panelists. So first, it is my pleasure to welcome Professor Arino. He is a member of the Center for Disease Modeling, the Data Science Nexus of the University of Manitoba, and a faculty member of the VADA graduate training program. Julian's main area of interest is population mobility, with focus on the spatiotemporal spread of infectious pathogens. In the context of COVID-19, he was contracted by Public Health Agency of Canada to work on local and global global COVID-19 importation risks. The title of his presentation is Assessing the Risk of COVID-19 Importations in Locations with No Ongoing Local Transmission Chains. So thank you, Professor Arino, for joining us, and the floor is yours.
Thank you. I think, can I make, is that full screen?
Yes.
Are you seeing my screen? Okay. So I'll very briefly go through some ongoing work that we actually want to submit very, very soon. And that's relative to importations. So I'll start by showing 2 pictures about the situation of COVID-19. So the first graph that I'm showing you here is the number of countries and territories that have imported COVID-19 as a function of time since the beginning of the international spread. So it's January 22nd, well, the documented beginning of importation. And for comparison, I've put the SARS timeline, which is somewhat, at the beginning, they were very similar, but what you can see is that COVID continued to spread internationally. The last known importation location is Lesotho, mid-May, essentially. So that's at that point. And so the idea here is that you have a bunch of locations, and each one of them at some point will report cases of COVID-19. I'm going to focus here on Canada, which is where I am. So here I'm showing the same thing, but a slightly different way. I'm showing you all those data are the, so in red it's provinces and territories, of which there are 13 in Canada. And in blue, it's the health regions of Canada. So there's 112 of them. These are subunits of health. And each dot here, each point represents a place that has reported a case in the past 3 weeks. So if you think about it, 2 weeks would be a quarantine period. I'm adding an extra week to that. And I'm looking at places that have reported cases within this 3-week period. So the initial increase that you see here on the left, that's entirely driven by importations. So that means it's a location that doesn't have some cases at that point, and that all of a sudden is importing cases. Okay, and so we're trying to understand what is the driver of these importations and how we can model that. So in a way, if you think about the process, essentially spatialization of an infectious disease is the repetition of what I'm showing you here. So there's a transport of the disease by being carried by an infected individual. That infected individual is transported or transports themselves to a given place. When they reach that location of interest, they first face a first barrier, which is the, maybe there is entry control, maybe there is quarantine or whatever. But upon importation, if they're infected, they join the population there. When they join the population there, they can either trigger an epidemic or not. And the idea is that there is this phase here that's amplification. And if amplification happens, then the local destination actually creates cases. And those cases then in turn can be exported. There might be exit control from the location. But if there's not, these cases go on and they are transported to a new place. And it's the repetition of this process that leads to the spatialization of the epidemic. So here we're focusing on this particular idea. So I'm stimulating a location by throwing cases at it. And then there might be quarantine or not. But so if there is quarantine, that might slow down the importation rates. But so I'm looking at a rate at which cases arrive. And then this is fed into a stochastic model, a stochastic epidemic model, which then reacts to these importations. And depending on the cases, we might see nothing. So the import case does not infect anybody. Things die out, there's no importation. There's no like local transmission chain. There can be a minor outbreak, so that import case might trigger a few cases, but that's it. Or there could be a major outbreak, which is what we want to avoid. So I'll briefly show the type of thing that we obtain. So here I'm showing you the average number of days between importation events. So I'm considering a rate of importation going from 1 day on average between importations to 50 days on average between importations. And also I'm looking at the effect of the effective reproduction number in the location, which in a way is a measure of the intensity of the non-pharmaceutical interventions there, or all sorts of measures that are present. And the idea is, okay, how does my system react to this? So what's the proportion of simulations, for example, that see local chains of transmissions? And you can see that in the lower corner here, I have very good control locally. I'm importing very infrequently. And so I have very few, so that's 40%, less than 40% of cases, I will see local chains of transmissions. But as the frequency, the rate at which cases are imported, I get more and more frequent local chains of transmission. And I mean, that's very not reassuring, because in this region, for example, everybody, every simulations essentially end up importing.
We have just a minute left, Dr.
Yep, I'll be done in a minute. But here, if you look at the pendant to this, is that the attack rate is much lower if you control well. So the darker those dots, the lower the attack rate as a reaction to the simulation. And the last thing I want to say is, okay, so we've also evaluated the impact of quarantine to this, because quarantine is this filter that gets people out. And so here I'm looking at this is the efficacy of quarantine as a function of the duration of the quarantine. And so that essentially is something that pushes you right in that previous figure I was showing you. And that's it. I'm done. This is put my last slide, but
Thank you very much, Professor Arino, for your research. I'm really curious about the discussions that which will take place after the initial presentations. Thank you again. Next, I would like to introduce Professor Jane Heffernan. She leads the Modeling Infection and Immunity Lab as part of the Center for Disease Modeling at the York University. Jane is an inaugural York Research Chair and is the director of the Mathematical Biology program at York. During COVID-19, she has been involved in Canadian provincial and national modeling teams. She also leads a pan-Canadian team modeling the in-host dynamics of COVID-19 and leads an international modeling effort on COVID-19 vaccine modeling. The title of her talk, as you're seeing right now, is a look at COVID-19 in Canada from a modeler's perspective. Thank you, Dr. Effernan.
Good morning, everybody, and good evening and afternoon for some of the participants. So I'm going to just briefly touch on a little bit of what Julian said, but only in one slide. And then I'll focus a little bit more on what I've been doing. But first, so I'm interested in immunoepidemiology. And so I'm interested in anything that affects the host that then affects either the host's susceptibility or transmissibility. And then at the population level, I'm interested in anything that affects immunity or prevalence of disease in the population. And so you can see that really I like to look at the multi-scale issues that have to do with a lot of infectious diseases. And so in terms of data for COVID-19, I've been using CyTOF and proteomics data to look at in-host modeling of the pathogen, to look at the differences between asymptomatic and symptomatic infection, and even resistance in terms of cross-immunity. I've been looking at how susceptibility and immunity and the initial conditions of someone's immune system can determine how severe an infection is. And so we're trying to distinguish between what cases might be reported and what cases might not be in terms of the in-host information, but at the population level. We're also interested, of course, in the upcoming vaccine and what types of effects we can have with this vaccine in different age groups in the population, and how this will be effective in people who have had it or have not, and looking at waning immunity. Of course, we're using social distancing data and data from past experiences in Canada with pandemics like H1N1 and SARS to look at the effects of media reports on social distancing behavior in the population. And then, of course, we look a little bit, not like Julian, but a little bit at the effects of importation. So mostly I've been focusing on the social distancing aspect, the in-host aspect as well. So I've got our in-hosts, and I've been translating this also to a healthcare model. I've been working quite closely with Health Canada and looking at the effects of personal protective equipment, but not just the effects, but also trying to determine what the demand of personal protective equipment will be in different health jurisdictions in Canada. In terms of importation, I just want to say that we did have a huge influx of importation in Canada at March break. In Canada, in the middle of March, all of the schools have a 1 or 2 week break. And the tradition is for all of these people, well, most, to go to different vacation places all over the world, but mostly to Florida. And so we do have a lot of imported cases from that March break with elementary school and high school students and their families, as well as we do have a pretty large elderly population that does reside in the United States in the winter. We call them snowbirds. And they usually reside in these states down here. And so during March break, we also, because of the call that we're going to close our borders in Canada, a lot of the snowbirds came home, but usually that's about the same time that they would be coming home anyway. So we did have a large importation. So some things that I've been looking at is trying to determine what the effective reproduction number is for different provinces and territories using data. So here I'm just showing what our plots look like for Ontario over time and New Brunswick. I've chosen Ontario and New Brunswick because my close colleague that I'm working on the Health Canada work with is from New Brunswick, and these are generated by the two of us. And then what we do is we feed information from a fitted model to different province and territory data into a workflow that allows us to determine how the current epidemiological states in different provinces and territories can be projected forward to look at healthcare demand. So looking at GP offices and emergency department visits, as well as ICU beds and ward beds and the length of stay in those, but then how that projects forward to look at what our demand will be in PPE usage in the healthcare setting. So you can see here that we use the fitted model. So this is some output that we can get from Ontario and New Brunswick. We fit it to current data. The red data is something that data that we don't use in the fitting, that we use to see how good our projections will be. And then we use these epidemiological curves of known cases and projected total number cumulative cases. But these are the epidemiological curves of severe and non-severe infections. And then we feed these through the workflow to end up trying to figure out what the PPE demand will be in the next 4 weeks or so for every province and territory. And I think we go as far as a year ahead. And so this is an example of some output that we can get. I'll say that this code was originally developed by colleagues in Australia, by Rob Moss and James McCaw and colleagues. But what we use this code to do then is to project what our PPE usage for different PPE sets in different healthcare settings will be over 12 4-week periods, as well as this should say N95, as well as N95 masks. You can see that this usage of N95 masks is really greatly driven by what the epidemic outcome will be in the scenario that we're looking at right now. So this is work that's done with a lot of collaborators in Australia, Canada, the United States, and it's supported by the Fields Institute, NSERC, CIHR, the Public Health Agency of Canada, Health Canada, and StatsCan. Thank you.
Dr. Heffernan, thank you. Thank you for sharing your research with us. Next, I would like to invite and introduce Professor Rijdenauer. And Professor Ben Rijdenauer's primary research focus is in applied mathematics and modeling dynamic biological systems, particularly those related to human health. Ben has led efforts to model the spread of COVID-19 in the state of Idaho. He has worked closely with the governor's task force and the Idaho Department of Health and Welfare to develop policies to protect the state's public health. The title of his presentation today is Modeling and Forecasting COVID-19 in Idaho and Beyond. Dr. Rijdenauer.
Thank you very much, and I'd like to thank you guys for organizing this great symposium. Let me see if I can get my screen share going here. Okay, let's go like that. All right. Everybody see my PowerPoint there?
Yes.
Awesome. Okay, great. So as Dr. Ogman mentioned, I'm talking about modeling and forecasting COVID-19 in Idaho and beyond. Right off, I'd like to just sort of thank the groups of people that I've been working with. Primarily, that would be our modeling group, which is the Institute for Modeling Collaboration and Innovation here at University of Idaho. Been working pretty closely with the Division of Public Health and the Department of Health and Welfare in Idaho as well to work on these models and get the best data we can for our models. And then I'm also a member of the University of Texas COVID-19 Modeling Consortium. So that's one of the modeling consortiums that puts together a model for the US and is one of the ensemble models for the US. And then finally, I'd like to thank NIH for helping fund some of these activities. So let's see. There. So I just always like to start off with a couple of quotes here for a lot of these things. My favorite one is from George Box, that all models are wrong, but some are useful. So that's one of the big challenges, I think, here with COVID-19 is sort of coming up with the right model and getting something that's useful at the end of the day. So there are a lot of questions, and we're learning a lot as we go along. So the models have evolved over time, right? There was this discussion or mention earlier about how some of the models have missed the mark maybe earlier in the pandemic. And part of that is because we really just didn't understand what we were supposed to be modeling. So, as we go on, we keep updating these things and making our models hopefully more useful. I'm sure they're still wrong though. And then the other quote that I like to use is this one from John von Neumann, which is, with 4 parameters, I can fit an elephant, and with 5, I can make him wiggle his trunk. So as I'll show you in the next slide, the model that we're using has a lot of parameters. And so we need to be careful about over parameterizing our system and trying to get correct data for those parameters, and not just having something that is a perfect fit. So here is the basic model that we're using, and this is the same as the model that University of Texas is using. And I put some equations over there that go along with this, but that's not really the main idea. Basically, we have a susceptible class, an exposed class, and then from the exposed class, things get broken down into clinical infections, subclinical infections, and hospitalizations. And from there, you can proceed to the ICU. Maybe you need a ventilator and you recover, or perhaps you die, right? So this is a very classic sort of SEIR setup with some elaborations on it. And those elaborations are ones that we've made so that we can provide public health with information that they're interested about. So with regards to hospitalizations and ICU use and ventilator needs, those are the main things that they've wanted to know from us. And so that's sort of the basic model. Then we take that basic model unit and we extend that to 50 cities within the US and 5 different age classes. So this is both spatially heterogeneous, and has multiple age classes. So it's a rather large system of equations by the time you're done with this. And obviously there are these rates that go along with each one of the steps in the model. So that goes to that von Neumann quote. So what are the data that we're actually using to try to parameterize this thing and do the fit? So first, there's the spatial part. We have transportation data that we mine from the state. They have road monitors that they place along most of the major thoroughfares in Idaho. You can get this for a lot of the US as well, where the amount of traffic that passes between various cities. So you can use that to get some idea of the travel network within the state or whatever region that you're interested in. And so that's what we've been using to get that sort of migration kernel between cities. Then we've been using Google mobility data for social distancing. So social distancing is one of the things that is really hard to get a grasp on and how it's changing over time. And the way that we've settled upon dealing with this is by looking at these sort of real-time data that come in from Google. I'll show you that in a little bit. We have line list data from the Department of Health and Welfare. So that's our gold standard. It's vetted data. They tell us exactly who got hospitalized, what age they were, so on and so forth. But it takes them a while to compile that data. So often those data will come in 3-4 weeks late. So that's a very slow moving data set. But then we also have a much faster, unverified rapid data set that comes in from this Idaho Tableau, which is, they quickly collate data that they get from hospitals, testing laboratories, et cetera, and they put that online in this Tableau. So we use that, as I'll show in a minute. And then finally, we have some contact matrices that we start out everything with, which is, these contact matrices are extremely important for the model, and we really don't have very good data for them either.
We have a minute left.
Okay. So modeling components, we try to infer the travel network. So that's strictly observational, like I mentioned before. Then we infer the hospitalization time series. Then we forecast hospitalization using a couple of modeling techniques there. Then we do a little bit of inference about the transmission reduction via the mobility data. And finally, we do some trajectory matching. So that's numerical solution of the ODEs using likelihood methods. Okay, so here are what these data look like that go into the model. So on the right-hand panel, this is the Google mobility data for Idaho. So we've composited that, and that's what this squiggly black line is. And then it gets smoothed out using a low S technique. And so you can see here what happened is right up at March, this is when our governor first put in orders, and then you can see this rapid drop down of the sort of mobility patterns within the state. And then we've had a gradual climb as we reopen, right? And so you can see we're now back to a level where we're almost at baseline. The left-hand panels show the hospitalization data that come in on the rapid data set. So this is hospital heads and beds in the top, and in the bottom, that's the number of patients in the ICU. And then here's just the case counts and case count onsets in the bottom left. So these are some of the data flows that we're using to try to parameterize the model. And then at the end of the day, here's what we produce for Department of Health and Welfare. I see the left-hand axis, the y-axis got cut off here. So this is hospitalizations in Idaho over time, and the black dots are what we impute from that, that gold standard data from DHW. So that's the hospitalization data that we actually try to fit, are the black dots. We forecast that out using the rapid data. So actually we fit somewhere out to about the beginning of July. And then the model is the black line here. And then we cross-validate that with these blue points here, which are the actual heads and bed data that I showed just a second ago. So what you can see is that at the end of the day, we have a model that does a fairly good job. We're forecasting out, about a month and a half or something here. And then, beyond that, this is sort of where we end things, right? We don't know anything about mobility patterns. So everything beyond where these blue lines are is just sort of an assumption, right? Okay. And so, yeah, I've touched on some of the issues that we have here. Obviously, the data are changing in time. We have continued shifts in behavior and social distancing and knowing how people are compliant with various rules. And then, yeah, we continually try to keep this thing up to date and predicting things the best we can. So with that, I'll say thank you.
All right. Thank you very much, everybody. And next, I'd like to introduce Professor Rao. He's the director for the Laboratory for Theory and Mathematical Modeling at Augusta University. His works on blockchain technology with hybrid models, epidemiological policies, and chicken walk models are widely discussed for their practical value. Rao's other noted contributions include his fundamental theorem in stationary population models and partition theorem in populations. So his title of his talk today is Artificial Intelligence Framework and Probability of COVID-19 Identification. Dr. Rao?
Yeah, thanks, Dr. Agman. And I want to thank you for the introduction, and Dr. Ghosh for taking trouble to communicate several times, and Dr. Mobai, and thanks to all. And yeah, I would like to start my presentation.
While you're getting ready for your presentation, about a minute left your talk, I'll say time, and then I'll hope you'll wrap it up within a minute.
Thanks to everyone involved in this event, and to all the previous speakers and participants. Today I'm going to speak about the AI framework model, that is the artificial intelligence framework model for identifying COVID-19. And this is the first model using the AI framework in the world to identify coronavirus. Back in February 2020, we published this work. At the time, there are no, before I went deep into the mathematical modeling and then understanding the data after the month of March. This came in the month of February, because at the time we don't know the severity of the cases in the US. And then when I developed the model, based on the CDC's guidelines and WHO guidelines, and then after that model development done, I asked my clinical colleague, Joe Vasquez, who's a professor of infectious diseases, to look at the model and then, make some clinical sense out of it. And then we together published in the IDSA, Infectious Disease Society of America's flagship journal called ICHI, Infection Control and Hospital Epidemiology. And the idea of this particular model is as follows. In the first phase, the model collects the data through mobile phones, the symptoms, the basic signs. And then at the second phase, thousands of data points collected are analyzed through the process, through the AI system in the hospitals. And then the individuals are sent instant alert within a minute, whether they need to go to confirm through a diagnostic test needed for them, or they don't have to worry. And then those individuals who have been sent an alert are asked also whether they need any transportation to come or they don't need, or if they have to go to hospital, where to go. At the same time, the corresponding hospitals are also will be sent information about the particular individual. Pictorially, if you see that, suppose this is geographical region, we consider geographical region, and the dotted line, within the dotted lines are the house, the house, and then the circles are the individuals within a house. And then here you see that some of the individuals, the blue color individuals are the respondents, and the yellow color dots are those individuals who have not responded to the survey. They're non-responders. So the AI framework will be applied on this data, and then those individuals who have responded, you see some of them are having red color circle. That means these individuals would need to go to the hospitals to confirm their status, confirm through the diagnostic test. And those individuals, you see some of the red color are also there among the yellow dots. That means those they are non-respondent individuals, but they also might have the infection in them, but they don't know. That's why the later our works, which I'm not speaking in there, we develop mathematical models to understand the underreporting. And
we have a minute left.
Study, yeah. So come back to that. This is the framework. The AI framework instantly it gives the information that individual need to go for further testing or do not have to go for further testing among the symptomatic individuals. And then the central theorem, what we proved was, in a geographical region, suppose there are n individuals are there, and out of them some individuals respond to the survey, and then what is the probability that small n1 number of identified, probability that these identified small n1 number of will be identified among the small n number of individuals who responded. What is such probability? That's what we proved, that is n1 multiplied by n square. I do have some slides to give you an overview of the proof, but I'm not going to run the proof now. It is there in the published article, but I will be happy to come back to these slides if there are any questions from the audience. And this particular study received a wide attention across the world when we published that work, and then we receive the consulting. I do regularly consult various airlines, and then the hospitals how to implement this particular framework. And I supplied also the data. Supplied also our Georgia State Governance Office. When they requested, I supplied what peak numbers and the mathematical model-based model-based predictions for the state. And then we see some of the key,
We need to wrap up the your presentation.
One of the upcoming, the technology news for the mobile-based technology. They also mentioned, and the campus technology, they also wrote a review on that. As I mentioned, there are about 200 media outlets. They wrote a review or presented in the TV and the CNN, Fox, major all the channels, and we received a lot of encouragement to go ahead and then
Okay, Dr. Rao, thank you so much. I am sure my co-organizers will join me in thanking all of our speakers. We really feel blessed with all the speakers with this and the previous webinar series. So next, we are going to go the part of our webinar series where we are going to direct predetermined questions to our panelists. So these questions will be directed to individual panelists, and they'll have a few minutes, couple of minutes to answer them. If time allows, I'll invite other panelists to make comments if they have any. Dr. Arino, we bring the first question to you. When it comes to predicting outbreaks more accurately across different regions, what data, for instance, time series incidents, mortality, seroprevalence, location-based services, social media data. So what data series is needed to make predictions more rigorous, and what is the purpose of using these different types of data, and especially how are they best being used?
So I think Ben actually mentioned a lot of these data sources. So figuring out mobility is a very complicated task, and you have a variety of data sources that you pull in to inform your mobility data. But I would say, for example, in COVID, what was highlighted in particular was the let's say vast heterogeneity also in the data that we get for the EPI data. That's one of the big problems we have, is that so travel data is typically something that can be trusted across spatial scales, because you can essentially say, well, for example, I use IATA data for air travel. That data is relatively trustable. But then, for instance, when you're trying to predict the spread between locations, one of the problems that comes up is that different locations have different testing rates, they have different case definitions, and so you're trying to connect entities that are not necessarily reporting the same type of data. So I would say, in terms of what we need, well, first of all, a good understanding of how people move is really like the underlying issues. So Ben mentioned, for example, contact patterns. There are a variety of mostly private companies that sell you access to phone location data. These are very, very interesting, but they're very, very expensive. And they're typically also very local. Once again, that's a problem that comes that, for example, I got some data for Canada, but most of it is from Ontario. If I want to use this data in Manitoba, then it's a different problem. Yeah. So that would be one of the things, but like in a more general sense, when we're working on a global level, what I presented concerns little units, but I've also worked like Ben, like a much larger unit. In this case, even getting a good definition of how people define their cases would be very useful, because we're trying to piece together information that is completely inconsistent across geographical units.
Thank you. Thank you very much. So our next question is for Dr. Heffernan. So over the past 6 months, there have been many changes as we learn more about the disease. For instance, a recent change in what we thought we knew about the length of immunity for COVID-19 or other biological information related to disease. These changes that directly affect the models. So, for instance, as the effective reproduction number fluctuates, these changes are affected for it. So, your question is basically in perhaps could be answered in two parts. One is, how robust is the number in capturing these changes, and especially how often does it need to be computed? Can you comment on the basically effective reproduction number?
Okay, thank you for the question. That's true that immunity can change, or how you develop immunity. In terms of the reproductive number, I think more of it in terms of how the infectious period varies with respect to different individuals and how they're experiencing infection. And so usually I think about the effective reproduction number in terms of reflecting how infectious asymptomatic individuals are in the population, because people who are symptomatic hopefully are staying home, or if they're severely infected, are going to hospital. And so they're not really affecting the spread of the infection. So really, I see the measure of R effective as being some measure of how infectious asymptomatic people are, or the pre-symptomatic period as well. So as we gain more information on how the disease is working in the host, we can update that. However, I think that the difficulty lies really in understanding not really just the average individual that's infected, but a specific individual, because their immune system, an individual's immune system, actually kind of predetermines how infectious they will be. And we do know that there are some cross-reactive immunities from other pathogens that are affecting how this disease infects individuals and how transmissible they are. So I can't really answer the question in a really good way in terms of looking at R effective, but just saying that we need more information about how this disease is affecting people in the host.
Thank you so much for your answer. Dr. Reidenaar, how is underreporting of cases, like false negative rates or testing issues, and especially the delay in not only diagnosis but also reporting results of the test being incorporated in data-driven models, and how their individual impacts can be quantified?
Yeah, so those are both huge issues, and I'm gonna point back to what Julian talked about a minute ago, which was sort of the heterogeneity in the reporting system. It's sort of astounding, even within relatively small. We have various public health districts within Idaho, right? And every public health district does different things, right? They have different case definitions, like Julian talked about. They report things differently. The delays in testing are different, right? So there's this enormous amount of heterogeneity in the system just as to how the data are coming in, right? All the data streams, you have to try to do this sort of unification of data streams at the very beginning. And it's a really challenging process to do. And one of the things, obviously underreporting is a huge challenge to figure out what the state of the system actually is, how many people are actually infected at a particular location. But what I think we're seeing now, at least in the US, is sort of an overwhelming of the system, right? In that we just can't process things fast enough, right? Like things are going as fast as they can. and we just can't keep up. So there's now this new form of underreporting that's just like, we don't have the manpower to get all the information that we need reported back in a timely way. And so all this leads up to those delays, right? And so like I talked about with my model, we use the hospitalization data from the state. That's our gold standard because we know they've been confirmed and vetted data, right? But those are very slow and it takes a long time. And so then we've turned to those faster data streams to try to forecast out a little bit, right? And those models work pretty good to forecast out a little bit and then eventually fit the models to those forecasted data. But you know, the longer the delay is, the worse your predictions are going to be. And you know, we're trying to combat that the best we can, but it's a real difficult task.
Yeah, thank you. Thanks. That it makes, when you answer it that way, it makes perfect sense. So Dr. Rao, we have the last question is for you, and your question actually can be, I guess, put it in 3 bullet points. So what's the importance or role of data-driven modeling in creating awareness of the cultural changes in the society? And how do you validate modeling based on validate modeling-based results on non-pharmaceutical interventions, like for instance social distancing, using face masks, that require behavioral changes using data available, and then how do we find basically additional data to validate all of these?
You're still muted, Dr. Rao.
You're muted, Dr. Rao.
Yeah. Thank you. I think this is a fantastic question, and I'm lucky to to get this. You asking me a very relevant question. And regarding the face mask issue, currently I'm regularly in touch with because the CDC. I work closely with the scientists of CDC, and the face masks. I communicated with them on the recent article that came in JAMA. With the scientists there, the chief medical officer at the CDC and other scientists at CDC, the question here is, we don't have enough data on the face masks, and the face masks alone, one of the conclusions came out of the article was the face mask alone would actually, if everyone uses face masks, it will take 4 to 8 weeks in the US to control the epidemic, which is not true. Because along with the face mask, we need to have the hand washing, other things, the behavioral changes. Many things have to go together to have the face mask. So that's that part, non-pharmaceutical control, non-pharmaceutical, like other social distancing. And regarding the social distancing also, like the social distancing also not very well defined. It is not like even though they're saying 6 feet or 3 feet, because I work closely with the clinicians, they are still not clear. This is nothing, no one is to be find fault here, but things are not very clear that if they are sitting in a same office, that means if they don't share any office space, still they get infected, or they have the same AC ventilators that is still affected, and still not, we don't have any data. And just as underreporting is very important, based on the underdiagnosis, what I understand is from the Ben's interpretation is that underreporting is mentioning, and part of the underreporting what he meant was, I think, underdiagnosis. So now the US has really picked up in diagnosis very rapidly. Whatever I understand is diagnosis is not meeting with the reporting. That's what if you just dig further into his interpretation. So all these into consideration, I think that currently, we are almost to finish our next model we are using PDE, a model coming with the PDE with the various factors considering into that, but we don't have data of some of the variables there. That's where we're trying to, collaborate with the various people. And did I miss any part of your question, or? Sorry, you are muted.
Yeah, no, I was muted. I'm sorry. Yeah, no, thank you. This was great. We actually have just a couple of minutes before we start choosing questions from the audience. Now, this is for all the panelists related to the questions that I directed to other panelists. Would any one of you would like to make any comments?
Yeah, I want to actually know. This is Arne. Because I finished my time, and one of the important thing what we are doing is to bring a important special issue of the very renowned mathematical analysis journal called Journal of Mathematical Analysis and Applications. And this we are looking. I'm one of the guest editors to bring a special volume. Along with Stephen Kranz and Juan Nito, and I'm leading the entire process where we are trying to bring the models close to the data, not in a routine type of take any differential equation model, put some parameters there, routinely calculate the eigenvalues, eigenvectors, putting something there, bring some theorems, and then ignore the data. No, not that sort of, we are not looking routine type of articles there. We want to really come up with an article, at least for second wave, we are ready to bring some conclusions. So if I could not show that slide because of the time is over. That's it.
Yeah, my apologies. So speaking of a journal, I'll put a shameless plug here for myself for the Letters in Biomathematics. The journal Letters in Biomathematics actually has a special issue on COVID-19 with rapid review process. And then more information about that is actually available on the website. So Dr. Rao, thank you for giving me a platform to put my shameless plug. Thank
Wonderful
you.
job you're doing.
All right, so during the next our remaining minutes, we are getting questions from the audience, and some of the questions are interesting, I think, and I am especially eager to see your view on those.
I would like to interrupt here, OJ.
Yes, ma'am.
Jane has some comments you made, I think. That's what you...
Yeah, sorry.
I'm sorry, I wasn't looking. I'm sorry. Go ahead.
I was just going to make a similar comment to what Julian and Ben were saying in terms of case data and different definitions in different jurisdictions. The same also exists with recoveries. So, which is important if you're thinking about how someone has recovered, what their immune system looks like, and also what their immunity might be in the end. And so when I get data on recoveries and actually look at data that's in-host modeling data, like pathogen load and immune system interaction data from different hosts, when a patient is modeled or determined as recovered in the data, I don't really know if that day where they've been recovered is 5 days after they've recovered, 1 day, 2 days, 5 days, and that all depends on the study, but also on how different jurisdictions are saying that people have recovered. If you look at different data sets online, you have all the different countries or jurisdictions listing recoveries, but those recoveries really mean different things in different jurisdictions. So looking at immunity is very difficult when you're looking at recovery data too.
Yeah, good point. Very good point. Thanks.
I'll just chime in. I was just telling Jane offline that I decided not to use recoveries because I think they're probably the most biased type of data we have. I wouldn't trust them. And so in all the fitting we've been doing, we looked at deaths. Even that we know there's a problem, but recoveries is definitely something that I don't even consider.
All right, thank you all. So I'm really curious about now your comments to some of the audience questions. So the first question I like to raise is to all of you, but whoever would like to grab it, just wave hands, and then if time as time allows, we'll all get a chance to answer these questions. So what level of testing accuracy is needed to give a more accurate picture of population spread, especially with the potentially high % of a symptomatic spread, and you use such data in mathematical models.
I can chime in a little bit on
Go
this.
ahead. Yes, go ahead.
I didn't know about what level. I mean, obviously, the larger the sample, the more accurate it'll be, right? So you would like to get as much sampling as you can, but the real issue, or one of the big issues I see, is that the samples are not random, right? The samples are people that have reported to a doctor's office, and maybe that doctor decides they need a test or not, right? So there's sort of two levels of non-randomness that go on there. First, you had to have been a clinical case, right? So you had to have shown up. And then the second part is whether your doctor has the ability to test you or is willing to test you for COVID-19. So those are two biasing factors to the data that we get there. And what I would really like, I guess I should say, is a random sample, right? Then we could see like more about the asymptomatic fraction that's out there in the population, and some of the more subclinical cases, right? I mean, people with mild symptoms, things like that. That way we'd actually have some numbers on those. Right now, at least in the US, we basically have no numbers on those fractions, right? So.
If I could actually chime in just for a second, when you mention random sampling, I think that's especially important with all the colleges getting ready for reopening. And one of the challenging issues is the cost of implementing tests to students on large campuses. So I think random sampling, as you mentioned, is really meaningful.
Yeah, I've been spending a lot of time doing models for various campuses in preparation for reopening or not reopening, maybe, depending on which campus you're at. And yeah, the value of sort of random sampling and contact tracing is really apparent when you model those two facets in terms of controlling the spread. So.
Would any other panel members, panelists would like to chime in on this question, or before I move on to the next question?
Maybe I'll say just a quick word. So one way to work around this, which is not a good one, but what we've started doing is we in our model we also we consider symptomatic and asymptomatic cases. But the way we're doing it is a sort of very ad hoc way, and it's more confirmed versus non-confirmed. So we lump together cases that are truly asymptomatic and cases that are not detected. So in a way, the fraction of asymptomatics in our model varies from location to location to accommodate the fact that there is different levels of testing. It doesn't make it good for prediction because, well, you get, when you're doing data fitting, you can get that fraction out of your parameter fitting, but it provides some notion of what you can expect the numbers to be for a particular jurisdiction, but it doesn't sort of address the underlying what's the fraction of asymptomatic cases, which is probably more a true process that we can look at across scales.
All right, thank you. Dr. Heffernan, there's a question directed to you. How can you test a human to see if they are asymptomatic but shedding the virus? Is there something you would ideally look for, even if the test does not exist today?
Sure. You can test for that in terms of contact tracing. So if we have a known case, then contact tracing is really important, and where they can go through and try to trace all of the contacts of that individual. And these individuals maybe feel really healthy, but they could, through contact tracing, be tested and show that they're shedding the virus. And so that is a way where we can get some information in terms of how shedding can happen in the asymptomatic individuals. There are also people, I don't know for some jurisdictions, but where I live, that now people can voluntarily just go get tested. There are some rules for some long-term care facilities, for example. If we want to go visit someone at a long-term care facility, we should be tested for some of them. So some people who feel totally fine and want to go visit a relative can go get tested, and they may find that they are infected and shedding the pathogen. So there is information like that out there. Getting a good, nice database of all of the information is something that's needed.
All right, thank you. This is again for all of you. If you like to grab the question, go ahead and jump in. How do you choose parameter estimation techniques as a modeler, which are being used to update parameter estimates as new data become available? For instance, Kalman filtering, particular swarm optimization, and so on. Shall I repeat the question? So how do you choose parameter estimation techniques as a modeler, which are being used to update parameter estimates as new data become available?
So I can pipe in with the very simple things that we've been doing. In terms of parameter estimation techniques, I mean, there's so many different techniques that can be used. And I'm sure I'm using very simple ones compared to some of the other panelists. But what we do is really try to get not just a parameter estimate, but a wide or as big a effective distribution around that parameter as possible. But we have been using case data and sometimes hospitalization data, and just very simple fitting, like even with just least squares in some cases. So that's something that I've been doing.
Can I answer there?
Yes, go ahead, please.
Yeah. Well, I completely agree with Jane there. However, the method, how my experience with the understanding the epidemics for various diseases and the parameter estimation, for the however strong a method may be, parameter estimation method, unless the data is not being properly used into that particular method alone would not enough. Method alone, what's called the accuracy of method or parameter estimation technique, whatever the method used, is not alone enough. I said that especially during the lockdowns, whatever the data I see, I closely interact with the clinicians. During the lockdown, the beta itself, getting a proper beta, the transmission parameter beta itself is impossible. Practically, I mean, even I can come up with a confidence interval, 95% of confidence interval for a beta, given beta. Still, during the lockdown, whatever you are getting, it is just a partial or a fraction of the true beta. It could be higher the beta, we don't know, or the lower the beta, we don't know. I mean, we means it's modelers cannot solve that question.
Thank you. Although we are at the time, but this discussion is really is amazing. So for my own curiosity, I will take one more question from the audience, and at the risk of going over about a minute or two. How can we validate our constructed models without using actual data?
I'll just do a quick thing about, and I think a lot of us have done that. So one thing we can do is evaluate our models, go back in time and look at what our models would have said, what our models would say about the future that we know. And that's, I mean, in terms of evaluating the the models, that's one way that sort of works. It's actually quite scary because often you realize that your models are making very bad predictions. So what we've been doing is we were running daily data crunching for the Public Health Agency of Canada, and then we went back to look at what our models would have said about, for example, the start of the epidemic. And when you look at this, you are often a little terrified at how bad your models perform. But I mean, that's, in my view, for now, that's the only thing we can do, is look back, sort of say, I don't know what's happening, although you do, and then look at what your models are saying about that future for them that we know now because it's in our past.
Yeah, I would agree with that. Like, it's very hard to do this, right? But using these cross-validation techniques where you sort of, like Julian said, you leave out a bit and you see how you predicted that part. And if you did well, you feel really good about yourself, right? So that's good. And then the only other thing is sometimes you have other data flows that can cross-validate your model as well, right? So that's also really valuable if you have another data set and you're like, oh, well, it worked great here too. So we can hope for that. But
all right, thank you. So
horrified, right?
With that, I would like to thank again to our incredible group of panelists. As I said, I really feel that we are blessed with the quality of our panelists and sharing their knowledge with us and help us understand this epidemic much better. So I hope this session has given us enough insight in comprehending some of the scope of mathematical models in pursuit of providing some answers to the challenges that we have been facing. This brings us to the end of our session as we look forward to the next series of this battling emerging and re-emerging disease, COVID-19. Our website has all the information about the upcoming series, and especially the survey link that you are seeing on your screen. That's really important for us. I would take all the participants, panelists, attendees, loved ones, relatives, pets, everybody, go and please share your feedback with us by filling out the survey. And if you participate, more information on this will be posted on the website. But if you participate to 3 webinar series, this is the second one of the multiple sessions. The Intercollegiate Biomathematics Alliance will provide free registration to the 2020 Symposium on Beer, Biomathematics and Ecology, Education and Research Conference, and also will provide reduced article publication charges in the Letters of Biomathematics Research Journal. I thank my deepest heartfelt thanks to everyone, participants and panelists, for joining us and making this session really exciting. I once again cannot overemphasize for you to share your feedback with us. And with that, I like to say, everybody, thank you and goodbye.
Thank you.
Yes, thank you.
Thank you.